So next topic is familial adenomatous polyposis. An 18-year-old male presents with fresh, painless rectal bleeding for 3 months without a change in the bowel habit. How will you assess him in the clinic? We will take a history, timing and nature of the bleeding, straining at stools, history of hemorrhoids, symptom of IBD, family history of bowel cancer and inherited syndrome, weight loss and abdominal pain. Perform general and rectal examination including proctoscopy and rigid sigmoidoscopy. There are no other red flag symptoms. He was adopted, so doesn't know his family histories. You see over 20 polyps in the ductum during rigid sigmoidoscopy. What do you do next? So I will attempt to biopsy one of the polyps in the clinic if I have the facility and arrange a colonoscopy on a prolonged slot, as he could have a familial adenomatous polyposis. How would you classify the colonic polyps? So there are 4 types: adenomatous, which includes sporadic, familial adenomatous polyps, including attenuated FAP, hereditary non-polypous colorectal cancer, and MYH associated polyposis. And number 2, hyperplastic. Number 3, inflammatory, including Crohn's and ulcerative colitis. And the last one is hematoma, juvenile polyposis, and Peter-Jeghers syndrome. So what is FAP? FAP is a familial adenomatous polyposis characterized by presence of more than 100 polyps by second decade. Most common adenomatous polyposis syndrome, and autosomal dominant inherited disorder characterized by early onset of hundreds to thousands of adenomatous polyps throughout the colon, and it happened due to the mutation in APC gene. What are the other types of adenomatous polyps are there? So it's sporadic. FAP includes attenuated FAP, and hereditary non-polypous chronic syndrome, and MYH associated polyposis. What clinical features characterize patient with FAP? Usually have family history, more than 100 polyps from second decade, less than attenuated FAP, and duodenal adenomatous polyps, extraintestinal manifestation and mutation in APC gene, Chrome 5 to 80% individuals on testing. What are the extra colonic features of FAP? So it includes all the ectoderm, endoderm, mesoderm region tumors, so adenomas and carcinomas of duodenum, stomach, small intestine, biliary tract, thyroid and adrenal cortex, and epidermoid cyst, pilometrixoma, osteomas, and funding gland polyps, and desmoid tumors, hepatoblastoma, tumors of central nervous system, congenital hypertrophy of the retinal pigment. The colonoscopy showed over 100 polyps confirmed as FAP with the genetic testing. How will you follow up this patient, and when would you offer the surgery? I would refer the patient to a specialist polyposis center, as the need for the regular surveillance and screening for the sequelae of the FAP and have 100% lifetime risk of the colonic cancer, so will require surgery. Surveillance: annual colonoscopy once polyps detected with chromoendoscopy or dye spray should be at the specialist center. Annual colonoscopy once APC confirmed the chronic adenomas needs gastroendoscopy (OGD) with forward and side viewing scope to view the ampulla. If no polyp detected, 5 yearly. If polyp detected, Spegelian criteria to determine screening intervals, anything from immediate surgery to 5 years. Small bowel screening with enterocolysis, CT or MRI, enterography or video, capsule endoscopy, family history of small bowel disease. Annual physical exam of the thyroid nodules, regular physical exam to look for the desmoid tumor using the CT ultrasound, most common cause of the death. What are the surgical options for these patients? So lifetime risk of colorectal cancer is 100% and difficult to remove all polyps endoscopically, so surgery should be offered as soon as is practical in gap year or summer holidays. And restorative proctoscolectomy, ileal pouch anal anastomosis with covering ileostomy, 2-stage procedure, no continuity, no retained rectum, no surveillance, no risk factors for cancer, risk of nerve damage during proctectomy and post-op pouch complications, and poor function with the pouch, reduced fertility in women, and annual surveillance with the PR and the flexi. If we do the colectomy and ileorectal anastomosis, 1-stage procedure, low morbidity, motile than pouch, better function than with the pouch, function, frequency and leakage, increased risk of rectal cancer and retained rectum, female rectal polyps over 30-year, mutation at codon 1, cumulative rectal cancer at risk of 30% by 60 years, and annual surveillance of rectum, and total proctocolectomy and ileostomy, no surveillance required, and permanent stoma. Thank you.